Good to go?
Yeah, let's rock and roll.
Let's do it. Welcome, everyone, to the Neurohumanities Network. We are a group of humanists, artists, neuroscientists who are interested in this intersection between these disciplines. We have to, first of all, thank our sponsors here. The Arts and Humanities Initiative has granted us a grant for the last 2 years. And then the American Academy of Neurology recently gave us this grant, the DEI Innovator Grant, which we're very pleased to announce. More will be shared toward the end of today's meeting. We have a large team of neurologists, of trainees, of artists, and so forth. We have a team of now multiple members spanning different continents, and we would welcome anyone who wants to join us, especially for our social media team. You can connect with us through a number of ways. We have monthly virtual seminars, as you see today. We have booster sessions. We also have a YouTube channel that serves as our seminar archive. We also have social media outreach via Instagram, Blue Sky, X, LinkedIn. You can reach out to us via email. You should also subscribe to our newsletter, where all new events and wonderful opportunities are being shared. We also have a website, and please take down those QR codes to look at what wonderful things our team has placed on our website. And it is with such pleasure that I'm going to announce today's speaker. I also need to address the fact that unfortunately the original speaker for today had a last-minute cancellation, but the wonderful Michael Stanley decided to present in his stead on a different topic. Michael Stanley is a neurologist. He's the director of cognitive neurology at Tufts. He's also a humanist, an essayist, an artist. He's many things, but he's also a field builder within the neurohumanities and a mentor to many of us here. And one of the motivators for the Neurohumanities Network, I would say. He's also a dear friend. And today he's going to be talking about something near and dear to his heart that he's talked about in the past. And it's the topic of the electric muse, a modern ion. And with that, Michael Stanley, take it away.
I want to thank you all for having me today, and I will not, unfortunately, be speaking about AI and meaning making. It is a pity that Vlad Bach cannot be here tonight. I do hope that he's able to reschedule because it would be terrific, absolutely terrific to listen to him. He's got some fantastic ideas. I am going to get my screen and working. Let me just get things settled. Yeah, okay, and slideshow, play from start. So you should be able to see me. Everything should be fine. So we hopefully will be able to go now. So thank you very much again for inviting me. This is a story that I know well and a story that I have interviewed and talked about. I've not presented it as such. And so literally, I think maybe 2 minutes before we went online, I was putting some last minute touches. So it is a little in the rough here or there, but I do hope that it is of interest and hopefully inspiring. So the topic is on the electric muse, a sort of modern day ion. So just before I begin, any disclosures? So I did not take direct care of the person being referenced today. I met her through a really medical journalistic capacity. I found her information after hearing her story. I called her up and I said, I think this is fascinating. There's a lot to discuss. There's a lot to learn. Together, would you be interested in answering some questions? I would say that if you really want a more deeper dive into her perspective and her reflections, kind of even long after this experience, I would advise you to tune in to Andy Horn's interview on stimulating brains with her, Niffy. I serve a sort of small facilitating role in that, but it's really Niffy kind of thinking back on some of these cases and stories, and there's a much more in-depth perspective and of course much more personal perspective of her. And then a small tweak that is, I think, a very, very small conflict of interest, but I should bring it up, which is that the trial for which she received deep brain stimulation, the sundials trial, had several publications in Annals of Neurology, and I am on the MAD for that, although that is not how I found her, because those studies were in aggregate. So just wanted to kind of preface that. So why Ion? Why a Socratic dialogue by Plato? Why should this have any relevance to deep brain stimulation? Or, well, it has great relevance to the concept of inspiration and the muse, and where creativity is ignited or come from or sustained. So I thought it was a kind of intriguing metaphor, and even a concretization of that metaphor makes it all the more intriguing. Pulled out a few quotes that I think are worth considering in this case from the dialogue. So in this dialogue, there's a discussion of, where do the poets get their stuff? Why, where does poetry come from in the poet? Is it totally a contrived thing, a traditional thing that's worked off of? Is it a kind of madness? And it's sort of the argument that's put forward. It's a divine madness. And so here's some quotations that I think are relevant. So the reason this all comes to be is that poets utter these words, the poetry of theirs, not by virtue of a skill, but by divine power. So an argument for inspiration, breathing in. For the poet is not able to make poetry until he becomes inspired and goes out of his senses and reason and is no longer in him. It's an ecstatic experience on the one hand and an inspiring experience on the other. The gods take away the minds of the poet and use them as their ministers. It's divine interpreters of this feeling, of these ideas, of these truths, if you will. Another line from Plato is about the seeing behind and seeing through the things, and poets help us do that. Now, the metaphor that unfolds the links this talk actually are a metaphor about the divine inspiration, the gods being like a magnet, the muse being like a magnet. And then, of course, the magnet has this power, and you touch one ring to it, and that initial ring is very, very strong in its magnetism and able to attract another. And as you get further and further away, as you work your way down from, the poets into the actors, and the actors into the painters, and and finally the spectator, the strength is weaker and weaker and weaker, but it is nevertheless this kind of power as a conduit that's working its way through. Now, I want to talk about the case of the electric muse. And I'll present first because we have people from all walks of life, all traditions, all backgrounds that are here. Some on the neurohumanities side, some on the neurohumanities side, and some squarely in between. So trying to hit it right for all. I'm going to begin with a quote about and from Niffy, and then a little bit of explanation about Parkinson's disease and some of its treatments, and then we'll go into these funny little nitty-gritty details that I have up forward here. So she began, one of the things she told me, she says, there was nothing vivid about my imagination growing up. And I couldn't stand art class in school or camp. Was not a fan of the arts and crafts sections. She always felt she was too lazy for art and that there was too much prep and that you had to wash your brushes. And she was like, no, thanks. She had no talent for it, she said, and she really wasn't very interested in it at all. As a child, she would be asked to close her eyes and imagine a scene, but nothing lit up in the back of her eyelids. The ideas came, but the screen remained black. Interestingly, this is a phenomenon that is called aphantasia, and there's some incredible work done by Isaiah Kletenik at the Brigham and Women's, which has explored through a very careful lesional network mapping about where aphantasia might come from, which of course allows you to ask the complementary question, which is where one might be able to inspire fantasia. Where might these fantasies come from, the vivid imagery in question? Going back to Niffy. She goes, I was an artist because I did ask her. I was like, so you never were an artist in the past? And she corrected me. She says, no, no, no. I was never an artist, she insisted. She says, I just wasn't a visual artist. She got her emotions through the piano, and her passion was Irish step dancing. She says to me that Parkinson's disease took both of these away. And it was, in fact, as she came to discover, that it was treatments of Parkinson's that gave her something else. We might even be very romantic around this and call it an abundant recompense or a sort of felix culpa. So Parkinson's disease affects the initiation and the smoothing out of voluntary movements. Faces start to petrify, legs ratchet as actions flee from a stiffening body, escaping through the voice or an appendage as a restless tremor, paradoxically called a resting tremor, because it is activated when the patient is not. Parkinson's disease is caused by the death of brain cells that make or produce dopamine. And dopamine serves as a kind of coin of the realm, a currency in both senses of the word, actually, in several related networks of the basal ganglia, which monitors and modulates both motion and emotion, will, if you will. And so, in the case of Niffy's Parkinson's, as it worsened, the frequency of the dopamine supplementation that she needed in these drugs called Sinemet or Retigatine, they became intolerable to administer because of their frequency or unmanageable because of their side effects. So she needed, in fact, a thing that was a pacemaker for the brain, a way of kind of sending signals in order to regulate that activity, which would then allow her to come down on the medications, reduce that side effect burden and that administrative burden, giving her better control of her symptoms without this kind of the weight of administering to her own care. So this kind of pacemaker, we call it deep brain stimulation. I've pilfered a picture off of the web just to give you a sense of where kind of in the brain we would be, so we've revealed that and where these leads would go in, and then it's hidden under the skin, and the little battery is right over in the chest. So she needed this pacemaker, if you will, implanted, and it gave the steady pulse of activity in very specific areas of the brain that normally would have been nudged by dopamine and into action. So in her case, she is a college-educated office worker. She had no visual artistic interests, training, or really pleasures. She was an Irish step dancer. She was diagnosed relatively early, one might say, in Parkinson's disease at about 47 years of age, with the tremor in the left hand being the predominant symptom. She took that medicine called Sinemet 4 times a day. She also took another medicine that works to affect or stand in for dopamine. She took that daily, and then she took a longer acting of the Sinemet at nighttime to help with the cramping and the kind of dystonias that she would get. That was all prior to the surgery. Now, we'll talk a little bit about the sundial trial, but generally speaking, it was used to treat dystonia and the motor fluctuations when they no longer responded optimally. So she was a good candidate. She underwent extensive neuropsychiatric evaluation to make sure that she would both be a good candidate for DBS, which is often done. There's a neuropsychiatric assessment that's done prior. In this case, they were spending a lot of extra time on the different cognitive domains because one of the outcomes that they were looking at in the sundial trial were cognitive deficits, depending on the placement, left or right, or some subtleties in its programming. So we really actually had a lot of data on her mood and her cognition, and these were with some mild typical deficits one might see in Parkinson's disease, some slowing of thought, a little bit of confusion, more multi-step commands, slight retrieval problem, just on the border of normal. She was otherwise in a good way. And importantly, in her background, no prior history of impulsivities. And indeed, while she was on a fairly robust medication, she didn't have any of these kind of impulse control disorders that you sometimes see. Now, after the surgery, her symptoms improved. Actually, she had about 4% improvement in the score. When we look at our patients who have Parkinson's disease, there's a universal scale you can use to kind of grade each of the components. And she did see improvement. And indeed, quite soon after, there was a reduction in the use of the medicines. So all overall outcome. If people want to learn more about the study in general, I've included here one of the outcomes of that study here on Neurology Today. But there were several studies that came. Harrison Walker is her that is got contact with in order to meet Nifty more. It's also look at them and try to inform us. Now, the tribulation, the struggle, the trouble, the therapeutic experience. So it was about 3 days after implant of the device on the right impulse, but not from an activated system. So we might do this lesson impulse and inspiration. It says that she was sitting at home, brand new kitchen in a house that they had just bought because she was struggling to move around their larger kind of ramshackly home. She couldn't go anywhere. She was all alone at the house. There was no real way of leaving, and she just felt suddenly this irresistible need, this incredible. The motive and emotive diseases have often this in-between state of a physical thing with an idea, sometimes even hard to put the idea to it or the word to the idea in it. There are sensations that come
Michael,
before.
I'm
Oh,
so sorry to interrupt you. I think we are missing a little bit of what you're saying. Would you mind starting again with the story of where of Niffy and in her home, and
sure.
Yeah,
maybe turn your camera off? I
Oh,
worry about the sound.
your connection is a little bit choppy. That's
Just
why we're
it
saying that.
was stable, but now it's going in and out, and we're gonna need to
let's
DBS
see if
this
that makes
one,
any
so
difference.
to make it smooth.
As in, we're sure
Absolutely.
your explanation was excellent. It's only that I don't know how much we got
Not a problem.
due to the
So,
connection.
yeah.
Thank you,
So for
Michael.
her, thank you. I'm glad you pointed it out. Better to do it now than later. Just see a bunch of blinking. So again, it was about 3 days after she went home after her surgery. She's sitting there all alone in a clean, crisp, white kitchen. She's got nothing to do, and she has this sudden feeling, this irresistible urge. And the urge has an idea with it. It has a purpose. It has an intention to it. And I would pause just to say that many of these movement disorders that straddle the emotion and the emotion have this urge one way or another, sometimes positive, sometimes negative. We think of tics or Tourette's disorder having an urge that has to be relieved. In psychiatric diseases of akathisia, there's an urge to move. There are many examples in which there's an urge and an idea. OCD has a sense and a sensibility to it. I would point out that when um, Umberto Eco was asked, what does it feel like? What does the creative experience feel like? To clean up his response a little bit, he said, it feels like the urge to urinate, the sudden, but this need that has to be relieved. So for her, she had this deep urge that could only be relieved if she painted. Now, she didn't like this idea, this feeling. She doesn't like to paint. She has no interest in art per se. And yet, nevertheless, there's this deep, physical, irresistible urge with the idea that it would only be relieved, the itch could only could be scratched by painting. She rummaged through her daughter's bedroom and she found in a closet an old acrylics kit. And in that acrylics kit, there were some brushes. And she says to me, she goes, I cannot tell you how bizarre it was. I really had no idea what to do with this stuff. But I had this picture in my head, this picture in my head of the horizon and a waterfall. I could see it clearly. I could see it clearly. And it was freaking me out because I just didn't have that kind of imagination. You recall that she had great difficulty with vivid imagery in her head, and yet here it was for the first time, vivid imagery that had to be executed upon. She had no canvas or painter's papers, so with nothing but a pure white kitchen, she made canvases of her cabinets. She says, I went on this compulsive painting spree. When I started painting these cabinets, I just kept thinking to myself, just kept thinking to myself, just kept thinking to myself, I have to finish this door because who knows what I'm going to do. And I felt so energized, having a ball, thinking, obsession, compulsions. Every cabinet was a different subject or a different style. Her husband home, very patient husband was, smiled and he said, I like what you've done with it. Over the next few days, she ran out of paint and space to paint, and so resorted to doodling on fly leaves of book mail envelopes. Every single space had to be filled, she recalled. It was like I was filling all the spaces psychologically with art. Her reflections and her intuitions, her hindsight, if you will, her interpretations and self criticism about what it was doing to her, what she felt it was, and the meanings behind it are instantaneous. She's thinking about this as it's happening. She's making sense of it in the moment. She's consolidating the sense of that afterwards in the retelling of this time and time again, whether it is on her website in an interview with her or me or you name it. These ideas start to percolate the biography of her works start to take form, strikingly different forms. Now, when the right side of DBS was turned on a few weeks after, because all of this productivity that she's had has been with just the implantation and the inflammation around the area, the just getting used to it and recalibration. But a few weeks after, when the thing was finally turned on, the inspiration intensified. She felt entirely at the whim of her electric muse. She says, it was like I was possessed by a teenage girl from the valley who had a lot to say. I was manic, she said. Sometimes I saw what I wanted to paint and begin to paint it, but then by the time I was finished with it, I was as surprised with the outcome as if you had dropped the thing off on my front door. Most mornings started like they had before. She'd wake up, she'd get herself ready, but about an hour later, a vague sensation turned into a sensibility, and these instincts coalesced into intuitions as she reached for the tube of paint, and this Dionysian frenzy of brushstrokes would begin. In time, she learned to appreciate that certain states of being manifested in particular palette choices, even if these choices didn't seem to be her own. Days took on not just a theme, but a color, and colors gave her insights into her disposition or hopes or outlook on the day. She says, when I was just starting, I had no idea what a pink day or a teal day was going to be. I would see things in terms of pulling up an emotion, joy or happiness. I would see fields of sunflowers. And as soon as I felt and then saw it, I would have to put it down in paint as fast as I could, almost like I'm afraid. It's so fleeting, it could disappear. I had always made my emotions get on and out through music. It was never visual. It's like an emotional acid trip now. Not all trips are good ones, she said. And pain as well as pleasure, anxiety as well as ecstasy could strike her. And she came to understand how the emotion and the motion were related. It's like I'm Sybil, She said, I feel yellow, and yellow to me is content, joyful, naive, free-spirited. My mind associates those feelings with certain images from my life. Like word association. You say blue, and I see vividly Holly Hobby. I see my bedroom growing up. It's the imagery in my mind that's new. I never saw things in my head this way before. The color associations are not culturally complementary, might I add. A black day for Niffy is not a despairing day, but one of negative space, something that is filled with potential. And if she's in a state for painting, the rest of the world freezes instead of her. She says, I can't stop myself. There's no way to pull away if I'm in the mood to paint. I don't stop for anything. Doctor's appointments have been missed, deadlines, trains, you name it. It's like the rest of the world doesn't exist. These flow states are not uncommonly described in a number of diseases that have movement components to it, just as in a number of cognitive diseases. And rare is the cognitive disorder without the movement, whereas the movement disorder without the cognitive. These things both contribute to the act that we call behaviors, these observable phenomenon that we put attributions to, that we hold each other accountable to, that we make sense of a self out there by the intuitions of what the self in here thinks about it, just like we do in looking at her paintings to get a sense of the meaning of the marks there. Now, after uh, the left-sided DBS was placed, she felt for the first time a capacity to refine the intentions of her creative impulses. She might still go on a 20-hour brushstroke blitz, but she could now order her thoughts and formulate a route for the trip she was about to take. She says it probably shows itself most in a study called Symbolism 101, seen here. I had had insomnia that night and started to draw out all the symbols I knew, mostly just to count them. I don't know if the counting was for counting sheep or more vanity of being able to show how many symbols I remembered. But once I realized I was counting them, I fixed on the number 101. I fixed on the number 101. It felt goal directed and controlled, even if I think it was such a high number just to fill in all the space on the card. Symbolism 101, seen here, evocative of a psychology course, was to many viewers a kind of Rorschach test. She says, people saw what they wanted to in it. They'd tell me what they saw and what it meant to them. And it wasn't usually what I saw or meant, but I'd intentionally play into that. There's a Native American inspired bear, and some guy thought it looked more like a crab. So when it came to coloring it in, I colored it in like a crab. That was my choice, not the DBS's. Different media disclosed different emotional states to Niffy, as well as style for her painting. Line drawing was not a frenzied, manic manifestation of released energies and drives, but was a careful concentration of focus and mindfulness. She says, the more fine detail there is in a work of art, the more calm I get. The line drawings require a really steady hand, which is funny because I only have a steady hand for about 30 minutes a day. But during that time, detailing, I feel perfectly normal as I am zeroing in on this. It's so peaceful. It's so incredibly soothing to feel steady. But of course, that peace comes at a price. One would think that her demon was unstoppable. And although the spark might be unsnuffable, Niffy's Parkinson's symptoms can sometimes taper it. She she still has periods of being off, especially if she missed or delayed a dose of that medication that yes, she still has to take. And during those times, she'll be stiff and slow in both body and mind. Those are my chalk days, she says. Chalk is forgiving. so forgiving. I enjoy the calm and intent when doing line drawings, but there's also this freeing state of forgiveness that permitting yourself to be sloppy offers in those chalk days. When asked about what she makes of her art, of being an artist in this visual way, she says she doesn't think of herself as an artist. She says, the pieces I'm most proud of, like the eagle seen here, which is so detailed and realistic. I can't believe that I did that. I remember it just came to me as I was making it. It just came out of the blue as I was making it. The highlights are white out that was on the table, and some of the lines are from an orange marker that was just lying on the carpet, she said. While the experience in meaning making that comes from reflecting on the art has helped her cope with realities of a progressive neurological condition, there doesn't seem to be a satisfaction, contentment, or necessarily a pleasure in it. She said, I never thought I was going to be able to do art, let alone get out of a chair. The DBS has allowed me to take care of myself and move in the world, but I still have Parkinson's disease, and it's a real roll of the dice if I'm going to be in tears on any given day or if I'm going to be okay with things. It feels like this stimulator in my brain is handing me a gift and saying, here, Niffy, this will help you process all this stuff. Parkinson's took my piano, but it gave me my paintbrush. The art is going to happen regardless. It happens to me. It'll be good, it'll be bad. Most of the pieces are complete accidents, but they allow me to reflect on something, a memory of times past, or points me towards processing what has, what is, she says, happening to me. My Parkinson's gets worse. Maybe this manic rush is a mission to get everything on canvas out before I can no longer communicate. These are my initial impressions, a short abstraction of my time with Niffy. I do encourage you to look at Andy Horn and my interview with her. She goes into details about the experience of Parkinson's, about treatment, about being a research subject, about being a person who makes art, even if she does not necessarily call herself an artist. I put on the right a collection of her images so that you can see the great variety of her work. She name is Niffy. I'm allowed to say it. She actually exhibits her work in a number of places across the country, and you can purchase her work. You can find it under her title, The Parky Artist. That's how she calls herself, and that is how you can find her work. I want to thank Dr. Pavan Vaswani, who's down at UPenn in the VA down there, because he was the one that first forwarded me the article, the case report that described her. And I thought to myself, some of those things seem right. Some of those things seem interesting. And I want to know all the in-betweens. So I never would have met her, I never would have thought about these things or made these connections without Pavan. So I want to thank him. Obviously, Mattia Rosso, who asked me, can I fill in? Which I think was perfectly appropriate because I had recommended Vlad. So if he can't do it, obviously I should be the one to tap in. I want to thank Alice Flaherty. She's helped me think a lot about Parkinson's disease, movement disorders, and expression in art. And I highly recommend you looking at her books and interviews. And always, Dr. Richie Kahn. Richie was my first history of medicine, first and foremost history of medicine advisor. I first met him as a medical student when I was at Penn Bay Hospital in the main track program. He's been a constant supporter and compass for me, and I look forward to seeing him and his wife, medical librarian in Toronto at the American Osler Society in May. So again, thank you all so very much for listening and staying tuned. I know it's a shorter talk, but I hope that gives us some opportunities for questions, answers, discussions. There's a lot of things in there that are just loose threads. And I'm, of course, very interested to hear what your impressions are, and maybe there's some potential follow up. I'm happy to get in touch with her and try to pass those questions along. Thank you again.
Thank you, Dr. Stanley, for this amazing talk. What a story of the patient. So this is time for a Q&A. Um, everyone, you can only in the chat or just raise a hand. Any questions or like any stories or thoughts you want to share? Everyone is welcome.
How do you raise your hand? You said you can raise your hand.
This is a
You
fun
can,
book.
there's
This
a
is a
react
very,
button.
Javi's
Oh, there's a
here.
react
it's a
button.
very fun.
Javi, for you, you don't need to raise your hand.
Yeah,
Javi,
Hi.
you can just
we
talk.
can see you.
it's a great book ending because I saw Xavi's grand rounds today, and so now he's looking at mine. So I think this is kismet.
No, this is great. I usually, I can't sleep if I do work things until too late, but I think I'll be able to sleep despite this. I was wondering, Michael, if you could tell us more about the method of doing this, and how you like talk with the patient and I was also wondering about, that the last article that came out about Oliver Sacks and the points
Ye-
that he couldn't help making some things up and reflecting himself in the patients that he saw and your thoughts about it and the urges that I think you may have when you are quoting patients with remarkable stories like that to embellish, and to what degree do you embellish and balance that with not making things up, and your
Yeah,
comments about this. Yeah.
I mean that's a talk in and of itself. It's actually a series of articles. Sachs's partner, Bill Hayes, wrote a follow-up to that New Yorker piece, which ended up in American Affairs. I think is the publication that had his thoughts on that. I did try to write something as a letter to the editor, both for the New Yorker and just as a separate piece, but there was no particular interest. The only reason, perhaps any of you might think, well, where does Michael Stanley get off wanting to write a piece about Sachs is I am privileged in being the only, still, I think, the only neurologist who hand curated his personal library. So I'm very intimate with his marginalia, his notes, something which the author of the New Yorker was not. She had access to his journals, but journals are one kind of audience, an audience that isn't necessarily even for yourself, as you realize what your position is over time. Um, and you could even see that in his books. The Oliver Sacks audience when he's writing to himself in college is very different than the Oliver Sacks writing in his books, but now a famous author, knowing that somebody's going to be looking at his books. So that's one of the other things is who's the audience. To get into your specific question, my approach to her in the actual taking of the history, and it is a taking of the history, we're not passive in that process. Very little of what I obtained for information is in the talk that I just gave. If I were to have written an occupationally flavored medical note, like a performing arts clinic note, you would have seen all sorts of stuff. What was, do you hold it with your right hand? Do you hold it with your left hand? How long do you actually practice for? How many hours do you think you do every day? What is the range of, I mean, all of those things are in there. Have you been looking at art lately? What are the things that sell the most? Blah, blah, blah. I mean, all of that gets in there. For her, um, what I do is I asked, am I allowed to record this, knowing that this will be deleted? I'm going to record our sessions talking. I'm going to use them for the purposes of quotation. So that's one thing. One is I have it. Now it could be silly of me to say, well, why don't you just hold on to it? And he said, well, if I did that, it'd be an awful lot of space in my house, you know. Um, but that is where I start. Patients are also, like everybody in this world, privileged to change their stories. Anybody that is taking care of a dizzy patient or has themselves been dizzy might find that they have described this 7 different ways in 7 minutes to 7 different people. So stories do change. They have to change. Consistency is a strange thing in nature. It does happen, but change is usually the norm. So that's one. The other is that I share with patients what I've written. I don't share the raw data, but I do share, like, for example, this talk is based in part on a short story that I had wanted to submit. I ultimately didn't because I didn't feel that I had accomplished what I wanted to do with the story. And so I'm still tinkering with trying to add more things in, take some things out. Um, but I show them when I say, okay, I think I might pass this around to some people. What did I get right? What did I get wrong? What do you want to change? And then you ask them why. They may say, "Oh, I never said that." And you go, "Well, actually, let me show you the video where you do in fact say that." Um, and then that's a discussion. That's very different than somebody says, "I don't want that in there." So and so would see this, and my loved one would think, that does happen. Um, that's one issue. The other issue that comes up is and you've been involved in the Shavi, the notion of first person, perspective, second person perspective, and third, right? And much of what she's describing, there isn't quite a word for it. I've even sat with her and sat with other patients. We've gone through, with Rogers Thesaurus, second edition, even the rhyming thesaurus, just to sort of say, can I get something that's going to come close? Sometimes it doesn't, and so you make the best guess of it. Um, or you try to figure out a term or a word that, while it reflects us in the cognitive thing, might give you a better understanding or a better metaphoric thing for the movement part. So they do lean on each other, these concepts, because you're describing systems, whole systems that are going wrong. So sometimes you're making those edits in the description or the adjective in order to try to show how the system is working or not working. So that's true. Um, what are some other things that you might want to know? I mean, this obviously is a presentation for us. Let's say I were to have submitted this piece to something like Wall Street Journal or National Review or New Yorker. You forget that there's an editor. And I think somebody like it's a little fuzzy for a critic to sort of think that everything that went to, New York Review of Books or London Review of Books was straight from Sax's pen and to the public eye. There's a lot of editing that goes between from me to them. And some you accept those edits, and some, to be perfectly frank, depending on who your editor is, you don't know that they were made until after. I've never written the term provider to describe a clinician. And then there it was in one of my pieces. And I am sure I didn't approve that, but somebody made a change at the end of it. So what are you going to do? So, these things do happen. Um, the other is that there's information. Last thing I'll put on this point is you're not privy to everything. Patients tell their doctors one thing and they tell their lovers something else. So my patient might tell me, I've never had any, sexual relations with that woman. And then you find out something completely different. So the point is, in a number of the cases that were presented in the Sachs situation, it is unclear or it's conceivable that Sachs was told in his reporting one story, and then years later, when someone is very popular and now wants to tell their story, they tell it differently. They're entitled to do that. And you, as the audience, are entitled to read multiple accounts and try to make sense of it for yourself. That's actually what most clinicians do. They are the 11 blind men and the elephant. You are trying to make sense of these. And I am particularly interested, Shavi, in some of your inquiries about thinking more about symptoms as signs themselves, that the report is in itself a kind of sign, as objective in a way as some of the things that we think of as being more objective. And I find that fascinating. And these problems that come up in medical journalism come up for that fact. So anyway, those are some of my thoughts in answer to your question. Um,
Awesome. Thank
you'll
you.
see conflicts. It's actually very timely because if you watch the Andy Horn interview where I'm facilitating. So it's not even there are some differences in what she says than what she said to me, a year previous. And is she changing her story? Maybe she's changing it to the more accurate part. Maybe what she told me in the thick of things wasn't quite accurate. Maybe in the hindsight, she's made sense of it in a different way. right? So that's true. That's also why the best thing you can do with a patient, just like with any person, any story, you know, is time. See them again.
Awesome.
Good
Thank you.
questions.
Yeah, Michael, thank you so much for the talk. That was great. And that's one of my favorite Stimulating Brains episodes, and I'm an avid listener, so that's saying a
Oh, that's
lot.
very sweet of you.
The A question that I've had, I think I've talked to Mattia about this before, actually. So, and I guess this is more a scientific question than a philosophical question necessarily, but were the leads actually firmly in the motor STN, or were they like touching associative or limbic STN? And also, did the symptoms change at all with the, like, were you able to were they modulatable with the device off, or was it more of a lesional effect? Um,
Well, it was discretely a lesional effect. So that's the first thing, right? Because with only a couple of days of it being implanted, without the device having been turned on, she was having these problems. And but the activation of the device intensified, particularly on the right. What you saw was we saw this the compulsiveness of the activity. Um, so that's one thing. Um, Also, we didn't get into it, but there's some notions that she brings up in her language which we could interpret. And this, I guess, going to Shavi's point about, when do you just leap to a metaphor versus making it a simile, is there's a great argument in that symbolism 101 painting. Is what at stake a horror vacui, fear of the void, which was a pathognomonic thing you'd see in schizophrenics who would paint and draw, filling, thing, versus an amor infinity, a love of the complications upon complications, like looking at a watch get more and more and more detailed. Her sense was the former. Sorry, was the latter. But you could describe it as so. Those are the kinds of things that become difficult. What I would say is, I, to the best of my knowledge, was able to show that her lead placement was compliant with the sundial's trial, so it was as accurate as any other. Its effectiveness was another way to kind of look at it, which is that she did get her symptoms relieved, right? But she did have this off-target effect. Um, Part two, one of the other reasons why I have not thought about publishing this more medically yet is we have been having great difficulty in obtaining, purely for communication differences across institutions. On emails, it's, yeah, I'll send you the MRI. Yeah, I'll send you the history of the lead changes over time, in terms of the programming. It never happens. Things get lost. That's the problem. But what we would do actually in that case, to answer your question, is we would take the MRI, and we would take the lead placement data correlate to when she had her, world's experts at being able to think about where the fields are, and then mapping that with lesionally to seeing if maybe, like, for example, now that Isaiah Kletenik has published the Fantasia paper, one question that comes to my mind is there an inverse correlation? Are we actually giving her Fantasia in a way that makes lesional sense to what has been proposed? A complementary sort of double negative thing, which of course is the world of the basal ganglia. But So yes, what I would say is they seem to be appropriately placed, but in terms of the manifestations of the actual programming, that could be a little far afield. Um, so, of course, the paper in question, the case study, does cite in a very kind of equivocal way, like, depending on where it is in the STN, we've seen symptoms. There's numerous papers that say that the mania should be decreased, but there's one or two that shows that it isn't. So we wave our hands. This is where I am not a movement disorder expert. There's at least one on the screen right now, so they could always jump in and spare me.
I think I just wrote in the chat, it's STN is super tiny. So I think even if it's your perfect lead, you can always hypothesize that edema and stimulation may bleed into neighbor areas, even if the lead is perfect. It also seems to be why STN may work better for motor science than GPI, just because it's so tiny that you put a lead there, stimulate, and you're pretty much hitting a lot. While GPI is a lot bigger, so then spatial precision matters more.
Thank you. Maria, do you want to go ahead with your
Oh, we
questions?
can have the other person raise. Oh, Corey. Corey, you go first. I'll go later.
This was a wonderful talk. It's what a cool case. I think one of the things that I was trying to decide, and I'm curious what you think of this, is do you think this was a problem for this person? Like, is she bothered by it? And at what point do we say that this is artistic expression? And at what point do we then go, okay, this is mania, right? Because I've heard you now say a couple times mania is this like side effect of it. And I guess the question is, do you think of this as, okay, a side effect of this was mania, or do we because some of it has to do with how bothered the person is. I'm curious what Charlie thinks of this too, and what we think is acceptable in society too, right? So I don't know what you think of that kind of spectrum.
Sure. What's the line from Steinbeck? Words are difficult things. They change their meanings right in front of you. So, if colloquially the patient is using the word manic or
Yeah.
mania,
Hmm.
but I am now quoting the patient, and you are looking at a person with behavioral neurological qualifications, you of course take it for granted that what I'm saying is that the patient was manic, or
Yeah.
that I
Uh-huh.
suppose the patient was manic, as opposed to just the patient was obsessional,
Yeah.
perseverative, or any number of things. So that's one of the issues. These great complications that we tie ourselves up in, and a very astute uh, literary mind, going back to Xavi's point, will make use of these ambiguities and
Mhm.
resonances of meaning to fit certain hypotheses
Yeah.
in their write-ups. I think Sachs did that.
Mhm.
I also think most people with NIH grants do that too with some of their work. So I don't think he's doing anything that anybody else isn't. He's just getting, dissuaded for doing it. Anyway, what I would say is it goes to your question of impulse control disorder and the greater problem of disorder in general, and the greater problem that we have in our diagnoses where we say things like, attention deficit hyperactivity disorder, autism spectrum disorder, right? And then there's a whole universe of people out there that say, well, it's not a disorder. And they are right. If the thing is disordering your life, then you may consider it a disorder.
Yeah.
If it's helping you order your life or reorder your life or see it in a new way that you find productive, generative, useful, or meaning making,
Mhm.
not necessarily a disorder, then is it? In fact, it isn't, because you haven't said that it has disordered you, right? Or disordered the world around you. Um, there are, of course, limitations. There are certain personality disorders which have no insight into the disorder that they are causing, but we will leave that as a small islet, on an otherwise general current that seems to be true. In her case comes a begrudging indifference and then an observation about its utility. It's actually a supplemental form of income, and a means of also making meaning. That this is a thing that she does, and it seems to be an escape valve or a way of trying to do something. Again, I think that romantic with the capital R notion of an abundant recompense or a Felix Culpa, happy fall, really is a good way of capturing the situation. I um, I fell upon a phrase the other day, personally, actually, that I thought described a situation that I was having that was pretty darn applies more generally, which is to say, uh, faith in many ways is to try to come to terms, but I'm going to try to work through this or try to accommodate it, right? It's different than making sense of the thing. And I think for Niffy, there are in the local features of her story meaning making. You see that in how she is making attributions to, oh, this color means this for me, and this color means that for me, and at some point it does. But on the more global level, I don't think there is that sense making so much as there is just a reconciliation of the self and its plight and how one comes to term. It's almost like a sort of denouement more than anything else. It's, well, this is just the way it is. Um, and a kind of being, a holding of that. Um, I think that's pretty close. So, no, I don't think this has disordered her. And I don't think that she would take this as a disorder. I think she does look at it as an exchange. I think that phrase of, Parkinson's took this, but it gave me that is, uh, is the kind of situation. In that respect, it maintains its very mythic position. It's a form of magic, right? Magic always comes at a cost. This is a good example of that. Um,
Yeah, awesome. Thank you.
Yeah, Mattia, please go ahead.
Yeah, no, wonderful talk. And I'm reminded in your talk of something that Sachs and a few others do, which is shifting frameworks. Like Sachs does it so many times in his books, where he shifts from a biomedical framework of how the brain works to an artistic framework, a philosophical framework. He talks about, as you know, he talks about Tourette syndrome as a Burkelian disorder, right? Or he frequently
that's
also
in his
talks
book.
about his patients with Parkinson's as being frozen because of being stripped of all the other potentialities, right? So I think this kind of framework, if you apply it to the arts and our ability to shift somewhat limberly from having the brain at the center of our universe to describe a phenomenon, to then viewing it from the opposite way, starting from the arts, starting from the muse, starting from magic or what have you. I think that thought experiment of shifting back and forth can be very powerful. And I haven't seen many people write up about this after sex, and you do too. So I'm curious about your thoughts about this ability to stay limber, not to keep the brain at the center, especially in the field of the neurohumanities.
Yeah, I mean, I think we're all knockoffs of Hermann Hesse's glass bead game. I think it's really what guys like me and Sachs, Sachs, me, certainly, he's a chess master at this. I'm just beginning, but this notion that if it really is all information, and you can put the information on the same metaphorical level, you can make it work that way. If it really does fit the grammar for that kind of substitution, rather than just a transubstantiation, but really just kind of substitution. So you can work the grammar over those ideas, over that information. If you can perform those computations validly, then yes, there's no reason why you shouldn't be moving ideas, moving information from one field to another. Those fields of subspecialization come for a couple reasons. They come from just the sheer vastness of the content of any given subfield. So that kind of subspecialization is just because you need to know a amount of a thing to be good at asking its questions or working on its methodologies. The second that comes from that obviously is protectional. I know a thing, you don't know a thing, that gives me some expertise, right? That's more of an economic situation. So both of those are open for pores. Both of those can be osmotic. You should be able to move that information around. Where it becomes difficult, I think, is where there are um, false metaphors or false associations, sort of Paracelsian problem, right? Where you go, well, it's a bone disease. I'll give him the bone of something else, and maybe that'll all work, right? I mean, that seemed like a good idea only because metaphor was so strong, but that's not the case for us now. So I think what a guy like Sachs does is he realizes that there is an order in the hierarchy of things, and that certain information can hop in or out of that order. He does it by using some very clever neuropsychologists. I think the Soviets, because unfortunately of the political structures that those early Soviet psychologists were working under, had to work around, work through, work over, work under a political regime of looking at how a society is structured. And so then you take that structure, something that you're trying to achieve or something that you just say natively is happening, and you are providing psychological explanations for that, or working to it, or working away from it. But Vygotsky, for example, and Luria, who learned and trained under him, take that approach that they go, well, if I start at a thing called cultural psychology and then try to work my way down to the the reduced experiments. That might be a better way of going about it. And Luria's great trick was to then say, well, if I create a case study of one, it's going to be a case study of a lifetime for which the information I know a lot about at a very reduced level, one cognitive domain like memory in the mnemonist, for example, is all to achieve asking a question for which the methodology is too flimsy. In this case, personality. He wanted to know what is the effect of an abundant memory on personality. And he goes, we don't feel confident in the psychology and the load-bearing walls of this thing that we're calling personality. Might not even be itself an entity, but I'm really confident about memory. So I'm going to at least follow these parts and I'm going to blend into it. And so that's why most of his things were, of course, historical. Marxism itself is a historical kind of approach to things, a contextualized version. So it lends itself to narrative, which then, of course, is what Sachs is doing. He's looking at the narrative elements of life. Um, that's a that's a one-off. That's a silly little product of where it came from. If it hadn't been Luria, if it had been a different guy in a different political regime, you would have seen a slightly flavored approach to that narrative, to that form of cultural psychology. But in the end, the basic structure is to be able to say, is it I start with internal tools and I work them out on interpersonal relations, or do I develop a structure where the thing really is socially psychological? Those tools develop there and then they are inwardly directed. And if that's the case, then the brain is a facilitator of that domain as opposed to being a producer of that domain. So it's a pulled by goals, pushed by drive problem. So that's I think where it comes from. So if Sachs is really not interested in asking questions, he's not really asking questions about the subthalamic nucleus. So we have a natural experiment in which the subthalamic nucleus gave him a phenomenon that he was particularly interested in. And then, like any good naturalist, you just collect a bunch, if they're comparative zoologists, you collect a bunch of shells, and then you can say something about it, right? You collect a bunch of phenomena that are close enough, and you can study the anatomy of it, you might be able to say something about it. I would also say, I am in the room with a guy who coined the term with Schwamm and phenoconsonance, which is another way of kind of seeing in one domain this activity, this action, this essence that appears in another. The guy walks the way he talks, the guy moves his eyes the way he does, these things. And then you say, well, does the guy make judgments the same way? I think Sachs is able to find the same sort of consonance across disciplines as opposed to just across domains of a particular discipline. That makes him more vulnerable because then you need to have people that can accept that they see the essence of what's that access is that you're playing with. And I think that hasn't held up well in a world of very few interdisciplinary people.
Well said.
Truly
Thank you for your
interdisciplinary people.
thoughts.
I think Sachs is really last of the product of what we would say are men of parts. I think Jonathan Miller was asked that. Why should why are you the only neurologist that's an opera producer, right? And he's like, well, it just happened that way, but it doesn't mean that any opera producer, every opera producer has to have gone to Juilliard, right? I mean, the question is, can you study the human condition and can you articulate behavioral facsimiles that seem to suggest that the person on the stage has that emotion and in such a way that it will react to you? Now, a great training for that is in medicine, just as well as it is training in a drama school. That's why medicine